Hi everyone, welcome to ResearchMD.com. Another great presentation today. Thank you for joining. Again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency and a transitional residency. I teach medical students and residents in the United States for the last 15 years. I'm also assistant professor of medicine, 2 large medical schools. We've been doing a series of lectures on hematology. We started with how to, with the anemia, like the production of RBC, and then we went into anemia, anemia due to iron deficiency, right? And then we talk about anemia due to chronic inflammation or anemia of inflammation, and then we talked about sideroblastic anemia. So we covered all those anemia where there's low MCV, right? And then now we're going into high MCV, right? So we talk about folate deficiency. Today our job is to teach all about vitamin B12 deficiency, which causes macrocytic anemia, or what is the other one? Megaloblastic anemia. Somebody tell me what is megaloblastic? You have a nice picture of megaloblastic.
Hypersegmented neutrophils.
Hypersegmented, what's the magic number? 5.
More than 5.
More than 5. Okay, so that is very important for to call it megaloblastic. So it's actually megaloblastic anemia. So let's start with everything. What is the first thing we have to do? Define it, right?
Yes.
So deficiency of vitamin B12 affecting DNA and the cell metabolism, right? And what does it cause? Like anemia and all of these other complications, right? So somebody tell me the definition one more time.
The deficiency of B12 affecting the DNA and the cell metabolism.
Okay, very good. Okay, let's look at the epidemiology. Very, very common, okay? If you look at worldwide, like in the developing nations, that's like 40 to 80% of the people in the developing world. In the developed nation, maybe less, but in the United States, the number, if it is greater than, if you're like 60 years older, then you can be like 20% of the people can have vitamin B12 deficiency. So when you see a patient, always kind of think about it. Okay, the other reason is like some of these people, they may not vitamin B12 deficiency, like 20% of them may not have anemia. Also remember that. Okay, so it's very important to think about broad differential. They don't have to have anemic to have vitamin B12 deficiency. So this happens only in what percentage? Somebody tell me.
80%.
Only 80%. 80%, everybody got that. Don't forget it, right? Just don't jump into it. I don't know. We might have to, this definition need to be changed. So 20% of the people might not have anemia, and you can easily miss your diagnosis. And what are these complications up here? Somebody tell me. Neurological complication, very deadly. So you could miss that. Okay, everybody got that important point. Now let's look at etiology. Okay, what are the gastric? You got main thing in the gastric, you got pernicious anemia, or any kind of surgery in the abdomen, you remove some of those parts, that's also called. Okay, then you look at the intestinal causes. What are the intestinal causes? Small intestinal bacterial overgrowth, SIBO, okay? Inflammatory bowel disease, okay? You can have parasitic infection. You can also have ileal resection, okay? Remember all those kind of things. Now, when you talk about pancreatic insufficiency, it can also cause pancreatic insufficiency, also cause like vitamin B12 deficiency, gastrinoma is like the other reason, and the most important again, the medications, you got PPI and the H2 blocker, and then you got alcohol, metformin. Remember, pay attention to metformin, okay? It's becoming very, very common. You don't want to miss that. That can cause vitamin B12 deficiency, right? What do we use metformin to treat? Diabetes, one of the prominent diabetes medication, colchicine, cholestyramine, and nitric oxide. What do people? It's a recreational drug. People use, young people can use. That can also cause vitamin B12 deficiency. And the dietary deficiency, malnutrition. There's like a vegan diet. Okay. We'll come back to the diet. And the congenital, there is transcobalamin deficiency, intrinsic factor receptor deficiency, and all of this is the congenital deficiency. Okay, everybody got that. It's very important. It's an extensive list of causes and all that too. Now, what are the clinical features? You can have anemia, right? Anemia, you can have fatigue, shortness of breath, the usual causes of like anemia. But some of them may not. 20% we say may not have anemia, right? And then what are the neurological causes? Okay, neurological causes also very important. First of all, you get dorsal column is affected. When you talk about dorsal column, you can have loss of vibration, pressure, touch, and all, and then you can have paresthesia, dorsal column loss. Okay, so dorsal column is affected, and then you got spinocerebellar tract is affected. When you talk about spinocerebellar, ataxia, gait problems that also come into play. And then you got lateral corticospinal tract also affected. So what's going to happen? You get like weakness, spastic paralysis, and all those kind of things can happen. Okay, so you got, I mean, let's remember, this is the, and then finally there's something called megaloblastic madness. Okay, you don't want to reach that state. Patient is be like confused, hallucinations, delirium. So it's not very good, right? So if somebody with altered mental status, I don't think it's a bad idea to check what? Come on, vitamin B12. Okay, don't forget it. Okay, just don't like you might look at it and say anemia, and then all of a sudden there's no anemia and there's no macrocytosis, but still that should cause like megaloblastic psychosis. Be very careful about it. Then unusual causes like there's something, I mean, it can also cause thrombosis because homocysteine usually can get elevated right here, right? Homocysteine will be elevated. So even in folate deficiency, homocysteine elevated, there is increased incidence of pulmonary embolism, cerebral venous thrombosis. Thrombosis is very common in those people. Always remember that. Okay, now we talk about all of this. Let's going into deep into the cell and to the stomach. What happens? Okay, we put them into like two parts. Let's start with what happens in the stomach. So in the stomach, let's talk about the diet. Somebody tell me, where's the vitamin B12? What kind of diet we should take? Somebody tell me.
Any dairy products?
Dairy products, vitamin B12 is there. What else?
Meat.
Meat products.
Eggs.
Egg.
Fish.
And all of that vitamin B12. What about if you're a vegan? What's going to happen? Can they get vitamin B12?
Yeah.
No, right? Okay, why vegans unfortunately don't have it. But in the body, like who else produce vitamin B12? Bacteria, colonic bacteria can produce, even though we cannot produce, the body cannot produce vitamin B12, but our friends of bacteria in our body can produce, okay? So that could also cause it. Now, what happens over here? Let's talk about when in the dietary vitamin B12 is already bind to a protein. So protein bound, okay? So you got a protein bound up here, they come through the stomach, and then they come up here, and then what happens is like the parietal cells produce pepsin and HCl, and they break this protein complex apart. So the protein is gone. So they break the protein. So you got free vitamin B12, but they're not staying free for a long time. The salivary glands secrete something called haptocorrin protein, and they bind together like an R binder, okay? And then that take the next journey right here. Everybody got that? So let's go back. So initial form is what? Protein bound, okay? They come through the stomach, and then when you come to here, in the parietal cell, there's pepsin and HCl production. They break that, make it, again, become free vitamin B12. Not for so long, right? And after that, the salivary gland already producing haptocorrin, and they combine together. Okay? Now it just keep its journey kind of moving along in the stomach, right? And then they come up here, and what is it called? It's the haptocorrin and vitamin B12 together. Everybody got it, right? And now it stops up here. What is the protease enzyme is going to do? It'll break them again. Okay? So now what happens? The haptocorrin is gone. Vitamin B12 again free. They start moving again. And what is the blue thing? In the stomach, in the parietal cell, they also produce something called intrinsic factor. Okay? So they now they're going to join with the intrinsic factor. They're going to move around right here and come to the ileum. This is where a lot of exciting things happening. So just go deep into the ileal cell and find out what's going on there. So what happens is like you got this vitamin B12 and intrinsic factor, they join the receptor, lysosomal enzyme, boom, they break it down again, right? So you got free vitamin B12. And they also produce something called, what is that? Transcobalamin. So the journey continues and they take and come to the blood, and there is this vitamin B12 and the transcobalamin kind of join together, and then what do we get? Transholocobalamin complex. And this is the one kind of go through the blood and they get stored where? Liver and the muscles. And how long is the storage can do vitamin B12? How long can this store in the body?
1 to 4 years.
1 to 4 years. What about folate? How long you can store the?
1 year?
Like I think it's almost like 4 months.
1 to 4. Okay.
1 to 4 months. Okay, 1 to 4 year vitamin B12, folate only like 1 to 4 months. Got it? Okay. Now let's look at the other molecular kind of thing. Okay, 3 things happening over here in this side. Okay, one is the Krebs cycle part. Methylmalonic acid is converted into succinyl-CoA. Okay, you need vitamin B12 for this part, right? So what happened if you don't have vitamin B12? What's happened to methylmalonic acid? Somebody tell me.
Increased.
It increased. So what the first part is the Krebs cycle is affected right here. Everybody got it, right? Now what is the second part? DNA synthesis is affected. That's why the cell becoming megaloblastic, right? So in that part, this is the second part of this. Homocysteine is converted into methionine. First, homocysteine kind of with the methylene tetrahydrofolate is using methionine synthase, and homocysteine converted into tetrahydrofolate. And this tetrahydrofolate is the one kind of used in the DNA synthesis. And if you don't have this happen, decrease nuclear maturation, decrease proliferation, macrocytosis, and rapid destruction anemia can follow. Okay, so we need to know that. So when we talk about this is the Krebs cycle part, and the other one is the DNA part. So you need to convert homocysteine and methionine, you need B12. If you don't have this, what's going to happen? What's going to happen to the homocysteine? Increase. So in these people, methylmalonic acid is going to be increased, homocysteine is going to be increased. In homocysteine, what else? What are the conditions it could be increased? Folate deficiency, okay? Because this is the folate kind of part up here. Homocysteine convert to methyl tetrahydrofolate. With the use of methionine synthase, they can become tetrahydrofolate. Okay, so if there's no folate up here, homocysteine also can be elevated. If there's no vitamin B12, homocysteine is going to be elevated. But in this part, folate doesn't have any role. Only methylmalonic acid and converted into succinyl-CoA, right? The part of the Krebs cycle. So we need to understand this too. Everybody got that? And we got a nice picture of hypersegmented neutrophils in the megaloblastic anemia right here. So this is very important. So which lab test we need to do all of that? Okay. Now, the next step is, the most important step is like, what are the investigations we have to do? Of course, right? We check our, what is CBC, and then we'll find the MCV is going to be, what is the normal MCV? Somebody tell me?
80 to 100.
80 to 100. In this people, usually like greater than 100, okay? Then you have to think about microcytosis or megaloblastic anemia. And what are the other things? You have to check for homocysteine. And then you check vitamin B12, and you also make sure you check for folate level also. Don't forget to check the folate. Okay, it's very, very important, which we'll come back to. So the first thing, we talk about check vitamin B12, the most important stuff. Okay, when you have vitamin B12, if it is low, or it could be low normal, or it could be, if it is greater than normal, you don't have greater than normal, that means like greater than 400. Some numbers you need to know. If it is greater than 400, don't worry about it. It's not usually vitamin B12 deficiency. But in this two part, you still have to worry. If it is in the low normal, in the middle, like 150 to 399, the next thing is to check what? Methylmalonic acid. Right here, right? We already said it's going to be elevated. Methylmalonic acid is going to be elevated, right? If it is methylmalonic acid elevated, so we have to differentiate, is it pernicious anemia or not, right? So what do you have to do? You check for intrinsic factor antibodies. If it is positive, it's already pernicious anemia. Okay? If it is negative, then you have to go another step, is check the gastrin level. If the gastrin is high, it's still pernicious anemia. If it is low, then you have to look about, it's not pernicious anemia, but you have to look at other causes of vitamin B12 deficiency. Okay? Very, very important. So let's say if it is very low already, You don't have to check the MMA. You just go into intrinsic factor and then check gastrin to make sure you don't have pernicious anemia. Okay? So you have to rule out pernicious anemia. It's very, very important. Now, you always have to check folate. Okay? Let's say what is the reason for that? There could be concomitant folate, vitamin B12 deficiency. It's a bad sign. When I say bad sign, you could have made a serious mistake in these people because you want to treat vitamin B12 first and then you give folate. Okay? If you don't do that, the patient can have subacute combined degeneration of spinal cord, which is a very, very serious condition. Okay? So that is why we always check for folate. If there is like concomitant vitamin B12 and folate deficiency, you treat with what?
Vitamin B12.
Vitamin B12. Somebody say it again?
First B12. B12 first.
B12 first. Everybody got that? Okay. So if there is, again, I'm going to say how very, very important. If there's concomitant vitamin B12 and folate deficiency, first you treat with the vitamin B12 and then you also have to give folate. Okay? Remember that. So how do you treat it? When you treatment, again, there is some studies like Cochrane meta-analysis done, and they found out you could just give oral cyanocobalamin. Okay, in the United States we use cyanocobalamin. In the Europe they use hydroxycobalamin. It's good to know like what kind of stuff they use, right? And even it's mild. Let's look at the dose. You get 500 to 1,000 microgram daily for up to you can give like 4 weeks, right? And then let me just write it up here. Just 4 weeks. This is 4 weeks, okay? Everybody got that? And then after that you do weekly for 8 weeks. And if the neurological damage, you better continue for like rest of your life, okay? And this, if it is very severe, you give 2,000 micrograms and then daily until the resolution of symptoms, okay? Remember that. So again, if you can also give IM, it's like 1,000 microgram, and then if the symptoms persist, you may have to continue this for a lifelong time. Okay, everybody got that? So now, remember, don't forget to treat with the folate deficiency also. It's very important to check, and you give folate also. Okay? So everybody got it? Like in a nutshell, like it's a big topic, but I think we covered like everything on like a single up here. I'm going to stand up here, actually kind of go over here and see, like, just look at it, where all this pathophysiology kind of look at it, okay? So, I'm just going to summarize one more time, just a little bit fast, why is it important? We talk about definition, we talk about the causes, gastric, intestinal, and the dietary modification. That's one word about the medication, PPI and H2 blocker. Where does it work? It works over here. Pepsinogen is converted into pepsin. Okay, so if this is interrupted, right, you cannot cleave this protein from here. That's where the vitamin B12 deficiency is happening. Okay, in metformin, the mechanism is still not very clear. I think there is something to do with the intrinsic factor and the calcium channel blocker. There's a lot of investigation still going on. Remember this part, and remember the Krebs cycle, and remember the DNA metabolism, how does it affect, and make sure you check for homocysteine, you check for vitamin B12, and go through the series of steps. Check folate, and then you can do oral cyanocobalamin. It's also IM we can give, and always make sure you give folate supplement. Thank you so much for watching today. We'll be back with another presentation. Please subscribe to our channel. We'll be back. Thank you.